Hello, everyone. As part of our Saving Lives webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I'm your technical producer. It is my pleasure to welcome you to today's webinar, Practice Makes Perfect, Implementing Mock Codes in Hospitals. And now, I'd like to introduce you to Janice Nichols, who is our moderator today. Janice is the Director of Education and Professional Development at Washington Medical Center in Fort Washington, Maryland. She develops community education programs such as stroke and heart disease awareness. Janice is a co-chair of the Code Blue and Stroke Committee and is also the data abstractor for a joint commission pilot relevant to process improvement of stroke care. Additionally, she is the clinical paramedic instructor with Montgomery County Fire and Rescue in Rockville, Maryland. Janice, welcome, and I am so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am, Emily. Thank you so much for that kind introduction. The title of today's webinar is Practice Makes Perfect, Implementing Mock Codes in Hospitals. Speaking today on this very timely topic is a colleague of mine, Nicole Kupchik. Nicole has practiced as a critical care nurse for over 20 years. About 15 years ago, she began working at Harborview Medical Center, a change that spurred an interest in resuscitation. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole founded Nicole Kupchik Consulting and Education. The speaker has disclosed the following relationships: Speakers Bureau, Physio-Control Stryker, La Jolla Pharmaceuticals, Consultant, Physio-Control Stryker, Baxter Healthcare. This educational activity is approved for one contact hour of continuing education for nurses and respiratory therapists. A link to obtain CE credits will be available at the conclusion of the webinar. The accreditation statement is listed below. Support for this educational activity is provided by Physio-Control, now part of Stryker. At this time, I would like to introduce my friend and colleague, Nicole Kupchik. Nicole, are you ready?
I'm ready. Good morning, everyone out there, or actually it'd be afternoon for those of you on the East Coast. I'm sitting here in Palm Desert, California, about to give this webinar, so super excited to be with you. But yeah, today I'm hoping you guys will get a lot out of this webinar. I titled it Practice Makes Perfect, Implementing Mock Codes in Hospitals. But super excited. I'm going to kind of walk you through the framework of how to implement mock codes in hospitals. And I successfully did this quite a few years ago, and I was just feeling like codes in general were pretty disorganized and pretty chaotic, and just that we had some things we needed to work on as far as practice. And so that's why I really wanted to bring in and start doing mock codes. So, and I'm going to really, I want you all to learn from my mistakes, because let me tell you, I made a lot of mistakes. I always do. And, but I want people to learn from my mistakes, so you kind of think about how to successfully implement these in hospitals. So learning objectives for this course, we're going to discuss the value of performing mock codes. We're going to talk about the importance of getting buy-in from the proper groups in hospitals. And I will tell you, I think this point right here is the most important when you're going to do system-wide practice or system-wide multi-professional mock codes, is you've got to get buy-in from the right people. And if you do, I will just guarantee you that if something goes wrong or you've got groups that don't want to participate, you can go back to administration that you got buy-in from and say, hey, listen, this is what happened. And I'll tell you some stories about that. And then we're going to talk about just kind of what it takes to implement mock codes, equipment, people you've got to think about. And then finally, we're going to talk about the importance of delineating team roles, because I'm definitely going to share with you what we discovered once we implemented mock codes. So the significance and background of just kind of resuscitation in general, I think in hospitals, we always have to remember that this is a high-risk, low-volume team response. And, I think if you want a team to perform at a very high level, you cannot expect a random group of people to show up who don't really know what their roles are and perform well. And so these types of things need to be practiced. Resuscitation should not be common in hospitals. And so again, you've got to definitely practice these things. Code teams often consist of healthcare providers who don't know each other, especially if you work in a big teaching hospital. You may not know everyone who's on your code blue team. If you're in a smaller hospital or an emergency department, maybe you will, but oftentimes people don't know each other and then don't know each other's skills or expertise. And then again, when roles are not delineated, it's like either everyone's doing everything or we forget about certain tasks, and it can often lead to confusion. And so that's why I think it's really important to, number one, have delineated team roles and then practice those roles. I think it's just so completely important. But a couple of things we do know from the literature is we do know that effective code blue teams that are associated with better outcomes have a rapid code team assembly. So you've got kind of an organized team who knows that they're on that team. They know what their roles are. They really focus on high quality cardiac compressions and CPR. You've got effective code team leadership. There should never be any doubt who the leader of a resuscitation response or a trauma response. There should never, ever be any doubt who the leader of that team is. Okay, so we're going to launch our first polling question because I want to know how many people out there are doing mock codes. I'm excited to know what's happening out there. Okay. Oh, this is interesting. Okay, so it looks like 28% of you are doing them regularly. About half of you are, it looks like maybe trying to do them, but it's inconsistent. And I'm definitely going to give some kind of key tidbits on that. It looks like 8% of you are considering it, and then a lot of you are not sure. Okay, this looks good. Now, we actually have another poll. Okay, so another quick poll for you guys. I want to know if you do mock codes, are they multi-professional, meaning you've got nurses, doctors, providers, nurse practitioners, PAs, RTs, PharmDs, or do you just do nurses only? So what do you guys, tell me what you do. So is it yes, the entire team, nurses only in the cath lab, you're thinking about it or you're not sure? So what do you guys think? Okay. Oh, I love it. So most of you are doing mock codes with the entire team. And I think that's really important. I'm actually going to really persuade those of you who are doing, who maybe are thinking about doing mock codes to consider doing mock codes with the entire team. I think there is some validity in doing them with your nurses only. I think there's some value to that, but really if you want to know how your team performs, you should be practicing with the entire team. Okay, so when you look at the data behind mock codes, surprisingly there's actually, I mean, I know I have lots of research on the topic, but there's not as much as you would think there would be. There have been a number of studies published. I think the trauma world has really tried to, they've been early adopters in doing kind of team training. The other groups would be pediatrics. I honestly think the peds have led, the pediatric groups have really led us in kind of hospital-based team training. The military, now so funny, I'll just kind of tell you guys my story about how I wanted to do this, but in 2004, I'll never forget, I went to the American Heart Association conference, and I heard Dr. Betsy Hunt, who is amazing. She's out of Johns Hopkins University. I heard Betsy Hunt give a presentation on doing mock codes in the pediatric population, and I was really wanting to do something in the hospital, and so I remember she's mentored me quite a bit over the years on implementing mock codes, and I remember talking with her and just kind of getting the step-by-step approach of how you would implement kind of a mock code from a system perspective. But really when you look at the literature, there's not a whole lot. And in fact, I'm going to be publishing an article about how to actually, a paper about how to set up mock codes. So let's talk about why you would do mock codes. And this paper was published back in 2008, and you can see the title, Survival from In-Hospital Cardiac Arrest During Nights and Weekends. So if you guys had to guess, now this is from 10 years ago, and then I've got a paper that was recently published. So 10 years ago, if you had to guess, do you think outcomes on nights and weekends were better or worse than if patients had a cardiac arrest during the day? And this was published Mimi Pepperdy and kind of a big group, the American Heart Association, published this paper, and what they found was that survival during, you can kind of see, I'm going to take my cursor here, but survival during day and evening hours, 7 a.m. to 11 p.m. were much higher than those during the nighttime. And so why would that be? Why would survival be better during the day versus night? And I think there's a lot of reasons for it. I think one being that you've got more experienced staff during the days and evenings. You've got more staff just in general. You've got more people going in and out of rooms. You've got families there that are paying attention and can alert you to early deterioration. But this paper made a lot of us stand back and go, whoa, is our hospital similar? And I will tell you, many of us ran our night and weekend survival and found very, very, very similar findings to this American Heart Association paper. So again, I think it comes down to a lot of things, but I think it's less staff, less resources, less family, and then less experienced staff being at the bedside. So, kind of on the tails of all this, there was this other paper published. It was a qualitative study where they asked residents in teaching hospitals, do you feel prepared to lead cardiac arrest teams? And to no surprise, they said, no, we don't feel prepared. And so this paper again led us to really rethink who we had running codes, because a lot of people thought, well, let's have kind of the more junior people run them to get experience, when really this is the sickest patient in the hospital. It should be the most experienced person running these codes with maybe your residents kind of on standby watching and observing and learning. And it all comes down to leadership skills. And you all know leadership skills those are skills acquired that take time and the maturity and experience. And there, as a novice in a hospital, you're not going to have amazing leadership skills. Those come with time. And then I don't know, like the older I get, I feel like, a lot of our residents look like this now. They look so young. And I really think we should be mentoring them and really priming them to become leaders, but they're not going to be leaders off the bat. So now, interesting, the British Medical Journal in 2016 asked the same question. What does survival look like during the nights and on weekends? And they did a risk adjustment survival for adult in-hospital cardiac arrest, and guess what they found? So they evaluated over 27,000 patients over the age of 16 who were in hospital cardiac arrest, and to no surprise, almost 10 years later, survival during the nighttime, you could see survival kind of goes across the bottom there. Survival during nights and weekends is much lower than during the daytime. And so again, I think it comes down to less staff being around, less family, and then also less experience. And so so they looked at different variables. So the first bar up here looks at return of spontaneous circulation for more than 20 minutes. And again, patients have the lowest rate of return of spontaneous circulation during the night and weekends. And then if you look at overall hospital survival, it's much lower during nights and weekends. And again, I think this begs the question, do we have adequate staff? Do we have the right staff mix in hospitals on nights and weekends? And I think most of you are sitting there kind of chuckling to yourself saying, yeah, right, that's where all the new people go. But really, should this be the practice if it's affecting outcomes? And I know I worked nights for a lot of years, so I mean, I get it, but I think these types of data should bring this really to the forefront of asking about skill mix on nights and weekends. So what makes an effective training program? And so this was a couple of different studies that really asked the question, when you've got effective training programs, what does this look like? And I think for mock codes, you've got to have regularly scheduled mock codes. So in 2007, I know we launched our program, and we decided 2 mock codes, so per month, 2 mock codes on days and 2 on nights. And we came in during the nighttime. We'd usually get in, once kind of, usually night shifts hands over at 7 p.m. So we'd get there around 10:30 and run the mock codes around 11 or so. And I mean, I think it's really important to really support and train your nighttime staff. But we also focused on individual and then annual team role training. And so I'll kind of go into this a little bit more in just a minute. But not only do we have the team training, but then we would break it down and work on individual training. So for example, our telemetry unit did documentation. And so we did team training with them, but we also separately did training individually with groups where we would run mock codes and have each of them document, and then we would look at the documentation. I also did resident training every month. So the first day that our residents came on staff, I would do training with them and run a mock code with them. And then it's amazing to me how many hospitals across the country, because I do a lot of traveling now, and I will consult with hospitals all over the country. And it is amazing to me how many hospitals do not require their leaders of their code blue teams, i.e. their physician providers, to maintain ACLS and BLS. I am continually shocked by this. And I really think that, you know, if you're going to have a team that is successful, you've got to maintain your education and training, you know, in ACLS and BLS. But the question, you know, is this enough? And, you know, if CPR is performed infrequently, skills are lost within weeks of training. And I'll actually show you guys a study on that in just a second. But you know, if you do in situ training with about every 3 months, you actually do see improvement. I think it should be done more frequently than every 3 months, but you can see this was a study that showed the start to getting chest compressions initiated went from 33 seconds to 13 seconds when they did in situ training. And defibrillation first defib times decreased from 157 seconds to 109 seconds. So you can make a difference by doing team training. And in previous webinars, I've talked about RQI, or Resuscitation Quality Improvement, but this is from the American Heart Association, and it's a really different way of thinking about BLS and ACLS training. So the idea being, instead of, you know, every 2 years going to a course and getting your BLS and your ACLS, that instead what you would do is every quarter jump on a mannequin. So you can see there's a laptop here, and it would have every staff listed. And then every quarter you would go to this mannequin and actually perform the skill. And why did AHA come up with this idea? Well, the reason was that skills declined rapidly after BLS and ACLS courses. So you can see within 3 months, skills precipitously decline. And so the idea being, instead of every 2 years doing training, quarterly, jump on a mannequin and show us that you can do this. Because if I had to pick one thing that absolutely matters in resuscitation, it is definitely going to be CPR and early and effective defibrillation. So, you know, again, these skills have just got to be spot on in codes. Now, when you're thinking about different ways to kind of implement training, there's lots of different ways. And I always try to insert training anywhere I can think of. So new staff orientation, critical care, progressive care, ED orientations for nurses or for physicians, unit-based. So we would do kind of unit-based first responders and kind of see what how that first response goes, and just focus on the first 5 minutes, especially on acute care or emergency department type areas. System-based, which is what I'm really going to start talking about here in just the next couple minutes. But, you know, again, evaluating the dynamic of your entire team. You can do things in the Sim Center. However, I am a true believer that if you want to evaluate your team and your team response, it needs to be done in the clinical area in which they perform. I do think that there is a role for sim training and sim center training, but I really think if you want to assess your team, it should be done in the area that they work in. And then finally, you know, resident education. You know, I always again, would first day of residents kind of coming on for their rotation, I would meet with them and do a mock code. And this is actually a picture on the right is a picture from like our pharmacists are part of the team, and we did pharmacy training and really talked about the meds and evidence behind meds, and then got them used to kind of the dexterity of rapidly opening epi or whatever medications we were giving. And so so I really think that there's opportunity wherever you look. Now, super exciting, just published. So this is literally hot off the press. Top performing hospitals for cardiac arrest. What do they look like? So how do resuscitation teams at top performing hospitals for in-hospital cardiac arrest succeed? This was a super cool study published by a group that collaborated with AHA, and what they did was they evaluated the 9 top performing hospitals from the American Heart Association Get With the Guidelines registration, a resuscitation registry. And so if you can imagine, they looked at this, Get With the Guidelines is a big registry for in-hospital cardiac arrest. They took the top 9 hospitals, did site visits, and they did 158 in-depth interviews with nurses, physicians, and administrators. And what do they have in common? And I'm going to just guess you're not going to be surprised by this, but this is what they've got in common. Number one, they have an organized team design and team approach to cardiac resuscitations. So it's not just random people showing up to a code. It's a designated, delegated team response and team design to their codes. They've got team composition and roles. So when you're running to a code, you know what your role is. And that, I will tell you, makes a gigantic difference. They all focus on communication and leadership during in-hospital arrest. And again, it's, when you've got situations, if you've got a cardiac arrest and you are looking around the room and you're saying, who's in charge of this arrest? Something's not right. It should be super clear. The leader should have a place they stand. They should announce that they are the leader. For us, they stand at the foot of the bed, arms crossed. They have a bird's eye view of the entire resuscitation, and they clearly communicate. And, we really over the years have taught, we've used team steps as kind of a communication training tool, but teach, think out loud, use that shared mental model, tell people what you're thinking, ask the team for their input. That makes a huge difference. And then finally, top performing hospitals also focus on training and education to keep that current of their code blue teams. And again, I think it's essential. So let's kind of dive into doing resuscitation drills. And this is a military model. And I know 12 years ago, when I was implementing MOP codes in a hospital, I really turned to pediatric and military models to just really get an idea of how these should be implemented. But the purpose is multifocal, right? So it's to identify any system issues you might have, and you might be surprised at what system issues you discover, but it's to evaluate your communication system. And when I say that, that comes in multiple different forms. I know a lot of hospitals still call their codes overhead, and so if you're doing so, do your operators know how to take that call? Do they know how to succinctly repeat the information and then successfully activate the team? And I'll tell you, we were having issues, and doing mock codes uncovered a lot of that. The purpose of resuscitation drills is also to assess and evaluate your team roles. And then finally, evaluate your quality measures. A lot of staff were saying, oh my gosh, it takes forever for the code blue team to get to a code. And actually, when we started drilling this, we found that almost the entire team was there within less than 1 minute. So it wasn't the problem that a lot of people thought it was. Do you have the right people there? And we really identified that we needed to create a couple extra roles for our code blue team. You can identify how long it takes to get chest compression started. I will tell you, most hospitals have issues with delays in getting chest compression started. You can evaluate interruptions in chest compressions. Again, that's a big problem at a lot of hospitals. You can assess time to defibrillation, airway management. Are you overventilating? There's so many metrics that you can obtain, but the one thing I will say is keep it simple. Don't overwhelm yourself. So where to begin? So let's talk about where to begin with mock codes. And I think the first thing is know your stats, know how you're performing, know your survival, know your immediate ROSC rates, and then really understand how many of these patients are getting, are being discharged from the hospital. And then I think the biggest thing, I cannot stress this next point enough, but get buy-in. Absolutely get buy-in. And so one of the things I did was I went to administration and I said to them, here's our survival from in-hospital cardiac arrest. A lot of people are feeling like we're not doing a good job. So I want to implement these multi-professional mock codes 4 times a month where we pull people out of their clinical environment into a mock code and perform. And once I kind of laid it out for our chief nursing officer, our chief medical officer, I went to the head of anesthesia, emergency department. Once I went to all of these groups, every single person said, you know what, this completely makes sense. This is a high risk, low volume procedure that we're doing. And I got complete backup, and buy-in from our chief administration. And I'll tell you, the first time that I did a mock code, I was scared. I mean, I was shaking in my boots. I was super scared to do it. And I'll never forget one of the first mock codes we had. The anesthesiology attending walked in, was super mad that they were doing that it was a mock code and not a real code, threw all of his airway supplies on the floor and walked out. And so I went to the head of anesthesia and said, here's what happened. And that person got talked to and it never happened again. And so I think one of the key things before you implement mock codes is you've got to very, very, I think, deliberately communicate that this is something that's going to start happening. And here's the expectation. The expectation is that you treat it like a real code. Other people to get buy-in, managers, nursing managers of different areas, physicians, obviously whatever physicians are running your codes, they've got to be bought in on this because you're going to be pulling them out of their clinical area for about 20 minutes. Code Blue team members, I think your entire team, has got to buy into this. Your Code Blue committee, obviously this is where a lot of it starts. Risk management, one of the things I always recommend if you are wanting to improve or get resources is go to risk management and find out, has there ever been a payout for a bad code? Because if there has, I'll tell you that you'll get support from risk management. And then finally, I think your patient safety officer can be one of your best friends if you're going to do mock codes. And then I also went to materials management, and this might be different based on whatever hospital you work at, but I wanted to go to the groups that restock and clean our crash carts and just let them know that we were going to start doing this. And so 4 times a month, they were going to have an extra cart that they're going to have to clean and restock, and just really getting buy-in from them. And then the other thing is I got buy-in from our chief nursing officer to actually use our real crash carts and use the real supplies on the cart. I mean, there's really nothing on that cart except for maybe like a crike tray or that's overly expensive. And so we got buy-in from the beginning to use our real cart and to use our real supplies. And I think that's key because people fumble with the crash carts and they really need to know where things are. So equipment, how do you get started? And I think the basic is that you've got to have a functional mannequin that you can do CPR on, that you can intubate and you can defibrillate. So I'll be honest, I started out with Brad. So Brad, many of you guys might have seen Brad. Brad is a mannequin that you can do CPR, you can intubate, and you can shock, but he's got no arms and legs. But that's all I could afford at the time. And so I also think you need to have a simulator or rhythm generator to use with your defibrillators to simulate different rhythms. And then I think a big agreement to use your crash carts. I think this is absolutely essential to be able to use the real supplies that people would use during codes. Now, mock codes, again, so like I was saying, we started out in 2007 with the goal of 4 times a month, 2 times on night shift, 2 times on day shift, and we would call them overhead as a real code. So no one knew it was a mock code. And so one of the things I always made sure to do was to do a sweep of the hospital. I would always call the rapid response nurse, we call it a stat nurse, and make sure that there were no emergencies, because I did not want to run one of these mock codes if we had an emergency going on somewhere in the hospital. So I'd always make sure that there were no emergencies going on, but we'd call it overhead as a real code. It would come through to pagers as a real code. So people literally did not know until they showed up that it was a mock code. And again, we started out low fidelity, and then eventually, I think quite a few years later, we moved to more high fidelity, full scale simulation mannequins. But I'll say the low fidelity using Brad, we nicknamed him Chester, just so you guys know. But using Brad, we were able to get it done. I mean, so I would say don't let the idea that you've got to have a big fancy mannequin stop you from doing mock codes. We would run mock codes in adult and pediatric scenarios, so we definitely would do peds, so we would just use a pediatric mannequin. And then, what we would do is I created a standardized form, and if anyone wants that form, just pop me an email, but I created a standardized form that we would use to evaluate kind of the metrics of the resuscitation, and then we would debrief after the simulation. So the way this went was basically I'd go in with, usually it's my physician provider, and we'd set the room up. There wasn't really much to set up. It was literally just throwing Brad in a bed, and then we'd call a code overhead, and we would start the evaluation from, I would start evaluating or assessing this situation from the time I called the code, because I wanted to know, how were the operators receiving the calls? Were they repeating the information? How long did it take for the call to go overhead? Then how long did it take to get to pagers? And, I was able to go to administration and say, unfortunately, because I wanted to stop calling them overhead, but we were, through mock codes, were able to show that there was sometimes a 4 to 8 minute delay for messages getting to pagers. So we couldn't go to calling them overhead. And then what we would do is we would run the scenario for 10 minutes, and then we would debrief for 10 minutes. And so the entire scenario never went more than 20 minutes, and we would always debrief. And I think that's key, is you've got to debrief. And so you can see this is a picture from one of our early mock codes with Brad. He doesn't have arms, doesn't have legs, but I have to say it was really easy actually to get mock codes set up using Brad, because I literally just threw him in a bed, and then people would, bring in the crash cart and bring in supplies they needed. So it really didn't take much planning. I just had to find an empty bed somewhere in the hospital, and we changed rooms all the time. So, I might have it on a mock code on a tele unit one day, ED the next day. We might do it in a procedure area. And then I always had like a dialysis room, just in case the hospital was completely full. I always had a go-to room in case there were no empty beds. But the great thing about doing low fidelity is it's easy to set up. You can't get really good CPR metrics on depth. You can get rate, though. I would just have somebody with a stopwatch counting the rate and then counting interruptions and compressions. Now, over time, we ended up going high fidelity. And the nice thing about going high fidelity is that you can get your CPR metrics and data. The only problem is the equipment's way more expensive. It's heavy. You need a tech to run the equipment, but you get really good CPR metrics. And it was kind of funny. So we used like I said, low fidelity for a long time, I think about 3 or 4 years. And the first time we brought in a high fidelity mannequin, I was horrified, because we just put the pads on Brad. So Brad was the armless, legless mannequin. And then once we brought in the high fidelity, I forgot about the snaps. There's like these metal snaps that you put your defib pads on, and we didn't use the right defib pads, and so the staff put the defib pads over the snaps, and we went from code blue to code red because we caused a little spark and caused a little burn injury on our expensive high fidelity mannequin, which I was horrified, but luckily we were able to get them fixed for pretty inexpensive. But I think the thing about high fidelity is that it is a little bit more realistic, increases critical thinking, because you've got something that's more human-like. And And it decreased the time to staff initiating code blue interventions because they weren't looking at like some unrealistic half mannequins. So, I think there's positives and negatives to both. Again, I just wouldn't let the fact that you don't have expensive equipment prevent you from doing mock codes, because I think both are very doable. And then once we got comfortable doing mock codes, we started drilling special circumstances. So for example, we would do drills in the cath lab. I'll never forget in 2009, H1N1 was a big deal, and so the flu, and so we would like run an isolation H1N1 room. And I have to tell you, I will never forget when we did mock codes during this time. I think as a facility really tried to enforce to staff, protect yourself. You are super important. Protect yourself first. And, again, we'd call a real code, it's mock code, but we'd call it like a real code to a room. And I could not believe how many staff members ran into a very clearly marked isolation room without putting on their protective equipment. And so, other things, we've done mock codes in public areas, clinics. The clinics, once they got word of, us doing mock codes, they were requesting them pretty frequently. You can also include your EICU areas. EICU can be super helpful in in resuscitations just in general. So don't forget about all your different areas. TB isolation, realizing we didn't have enough PAPRs for all the people that showed up. So then really it's just focusing on essential staff that need to, go into the room. And so these are just some different ideas of other circumstances that you can drill. So our metrics, here's what we evaluated. So we started by evaluating at the beginning of the mock code our alerting system. So the paging operator, did they take the call? Did they repeat the information? Did they call it overhead correctly? How long did it take for the message to get to our pagers? Then we evaluated first responders in the code blue team. So how long did it take to do a pulse check, get compression started, first defibrillation, and then time of first airway intervention. Then we looked at quality of compression. So how fast were we compressing? When we got high fidelity, we could actually measure how deep they were compressing. We looked at time off the chest. So we would run these resuscitations for 10 minutes, and I usually would have somebody standing there with a stopwatch, literally clocking how much time we were off the chest. Ventilations, how quickly were we ventilating? Because let me tell you, we were ventilating really fast on a lot of patients, on a lot of mock codes. And then finally, the whole communication, in leadership. Do we have somebody who clearly identified themselves? Did they stand at the foot of the bed, arms crossed? Communicate? Did they do callbacks? If the leader was saying administer 1 milligram of epi, did the medication nurse repeat 1 milligram of epi is going in? And so we would evaluate roles and how everybody functioned in their roles. And then this is I know you can't really read this, but a couple things that we did is I would always, again, do a sweep of the house, make sure there were no emergencies, and then I would just notify key people that we were doing a mock code. So the head of anesthesia, I would let the lead know. The nursing supervisor would always let them know. The stat nurse, but I would always just make sure everybody promised, not to let anybody know. I would also contact the head of respiratory therapy, just say, hey, we're doing a mock code. Don't tell your staff, but are there any emergencies going on right now? Because again, I didn't ever want to pull anybody out of a real clinical emergency. And then these are all the metrics that we quickly evaluated. And surprisingly, I was able to do a lot of these just myself. I had just had a clipboard, and I would just stand in the back of the room and would evaluate, the call to the operator, announcement overhead, arrival of each person. And you can actually do this with one person if they're used to doing it and know what is on the form. And then what I would do is we would run these mock codes, we would debrief, and then usually once a month I would send out an executive summary to all the nurse managers, the head of anesthesia, head of the medical and cardiac residents who ran the teams, the chief resident, nursing leadership, respiratory therapy leadership, pharmacy leadership, and I would just send out a summary of the mock codes and then a summary of what key things we need to work on. And so I definitely wanted to get this information back to the teams so that they know kind of how things are going with mock codes. All right, so now imagine you've called the code overhead. Your team has showed up. I would give them very little information. I would just say, I just found this person pulseless. And if the team would ask me for information like what's their history, I would make up something, but I would make it super brief. I honestly wanted them to focus more on the resuscitation versus kind of the minutia of detail. And so I would give very little information. I would just say, you've got somebody who's pulseless, just you need to deal with that. And then what we would do is we'd run it for 10 minutes. And then at the end of 10 minutes, we would stop it wherever we were, just being super mindful of everyone's time. And usually it would be me and a physician that I was running with. And we would say, okay, everybody, let's close the door. I want everybody to stay. And first of all, we want to thank you for participating. We know this is valuable time away from your clinical area, but we want to thank everybody for participating. And then we would ask 3 questions. The first one is what went well. And as you can imagine, sometimes staff had to be really prompted to talk about what they did well. I think many times staff sit there and beat themselves up. But you know, if they couldn't like say what went well, I would kind of maybe say something I noticed, but I honestly tried to talk very little during the debriefing. I wanted the staff to talk. We would ask, what could the team do different next time? Instead of saying, what can you do better next time? We'd say, what would you do different next time? And then finally, were there any safety or equipment concerns? And then I would just always reiterate to them, you know, I'm the chair of your Code Blue committee. If in real codes you ever have equipment concerns, I'm the person who needs to know so I can follow up and take care to make sure, you know, that we follow up and that you don't have these issues in the future. And then I think one of the things we try to do is when we debriefed, just set the guidelines of, you know, this is a safe environment. We want no blame placed on anyone. We really just want people to walk away learning and feeling comfortable that in your next code, you might perform differently based on what you learned today. And I think one of the biggest pieces of advice I have to give to people is be serious. Don't make a joke out of these mock codes. You know, don't be giggling, don't be laughing. Treat them very serious. And I'm not saying that there's not, because trust me, I'm like the biggest jokester ever. But if you start creating an environment where you're kind of joking around, it doesn't turn out well. And you want people to treat these like a real code because you want to see how they perform. So what did we learn by doing mock codes? A lot of things is that number one, we need to focus on the basics, CPR quality, defibrillation. We had issues getting capnography hooked up. So in 2010, with those guidelines, there was, you know, a recommendation to start using capnography, and we did a ton of training on capnography with staff. But one of the dire mistakes I made was we didn't put anyone in charge of it. And so if no one's in charge of applying capnography, it doesn't get applied. And so we went back to respiratory therapy and asked them if they would be in charge of application. And we learned this again from mock codes. We were ventilating too fast, so we had to give feedback to slow down the ventilation rates. Leadership, again, we transitioned from more junior people running codes to more senior people running them with the juniors kind of in the background. And then we had to retrain our operators. That was a kind of an interesting finding, is that our operators were not equipped to adequately call these and call the codes and initiate the response. And then finally, you know, during the nighttime, or actually during the daytime as well, teams had trouble getting to codes, so we created keys that they could call the elevators, and that they would have priority on the elevators. So again, another thing we noticed was that we had problems with Peri-shock pauses, and I've shown this video before, and it looks like it's running a little bit slow, so I may not totally run this, but anyway, during resuscitations, you can kind of see they're running the mock code and they're off the chest for a long time before they shock. And in this scenario, this is a team training. They were off the chest for, almost 30 seconds prior to the shock. And so we knew this was something we needed to work on. And so what we did was to decrease the time to defibrillation was that we started having staff, let me go back, sorry, I got a little trigger happy there. We started having staff pre-shock or pre-charge the defibrillator so that at a minute 25 they were ready to go. So anyway, I'm just going to go ahead and move forward here because just because of time. And then, like this video is, again, sorry it's running slow, but I always say are humans as important as NASCAR. I don't even think this is NASCAR. I actually think this is Formula One. But anyway, but you can see, I looked at this model of, a team that you've got a car racing in and you've got a team that quickly needs to form and do some primary functions of changing tires and getting this car ready to go back in service again. And I think this really, like, I wanted to emulate what this team was doing. If everyone knows their role, then they can very quickly assemble, do their job, do it much more efficiently, and maybe that could lead to better outcomes. And so I love the whole pit crew approach. And, so I'm just going to start wrapping it up with talking about just challenges in hospitals. So how many different combinations of code teams could a hospital possibly have? And I ran the numbers at our facility, and when you look at attendings and residents and ICU nurses and anesthesiologists and RTs and pharmacists and people who record and rapid response nurses, and you could have over 1 billion different combinations of code blue teams. And so that's why I think it's really important to have super delineated roles, but have very delineated roles. And I've shown this in previous presentations, but this was the first drawing that I had made up of our first stab at kind of role delineation. And you can see, we've got anesthesia and RT at the head of the bed. We line up compressors. Our telemetry nurse was in charge of documentation. More senior residents running the code with a junior resident thinking about and observing, thinking about the code. And then somebody who pushes meds, somebody who defibrillates, and then the pharmacist to push meds. And then over time, this transformed, and we realized we added this position of an operations nurse, where basically their role was to work with the team leader to just make sure that the code is running smoothly, and they really focused on CPR quality. And then, we brought in public safety and spiritual care because we wanted families to be present at bedside. And so we would kind of train that. And in fact, in a couple mock codes, I would position somebody to act as the hysterical family member who's just losing it during the resuscitation. So we would practice on, what would we do if we had a family member that was kind of losing it. And then you can kind of see with real people in position what this looks like when you've got all your team players. So somebody who defibrillates, the pharmacist who gets meds ready, the code leader, the code whisperer, so somebody who can kind of work with them and make suggestions, and then the operations nurse who works closely with the code leader, and then your airway people, and then you've got people lined up to do CPR. So this is what it would look like, I think, over time once your roles get delineated. But, really focus, I think a lot of work needs to be done, with your team leader in that, they're able to coordinate activities amongst their members, give concise explanations about why they're recommending what they're recommending, take charge. They announce that they're the code leader. They stand at the foot of the bed, and then think out loud and then ask the team for suggestions. I think this person has to be assertive, and they've got to be really respectful in communication, and then always close the loop, once orders are given on communication with the team. Now, another thing we found from doing mock codes was that we had a lot of people showing up to codes. I always say, who shows up to your codes? And many times it feels like this, like you've got so many people. And so a solution that we came up with, I'm not sure it was the best solution, But we had this idea of getting lanyards made up that said code blue team. And, we're in Seattle, so I did them in Seahawk colors. That's our football team, but our Sounders, our soccer team. But we had these lanyards made up that said code blue team, that the people that were assigned to the team would wear these lanyards. And for a lot of people, it was almost kind of like a badge of honor. And I know, funny enough, to this day, we implemented these 10 years ago. To this day, the one group that absolutely wears them are the physicians. And it almost kind of like became a badge of honor, to wear these to signify that you're part of the Code Blue team. But I think this is an idea to really deal with crowd control. And then what we did was we had our nursing supervisor positioned at the doorway, and they would kind of act as the bouncer, and then just look for people who had lanyards. If you didn't have a lanyard, you were asked to take a couple steps back, or maybe we would position you outside of the door. So potential problems with mock codes, again, high fidelity versus low fidelity. I think there's pluses and minuses to doing each of them, like I talked about earlier. Making sure people take the mock codes seriously. A potential problem would be pulling people away from their patients to do the mock codes, but again, limited. 20 minutes max was our time, and then I would always do a sweep to make sure there were no emergencies. Covering all shifts. Is the data collected realistic? And I'll be really honest, I think the data that we collected during mock codes was way more realistic than what we collected during real codes, because your code documentation form in a real code is only as good as the person documenting. And so, there's lots of positives to mock code programs in that it increases staff satisfaction. I mean, we literally went from teams that were like, oh no, a mock code, to people requesting them. I would have physicians literally emailing me, texting me, requesting that we do mock codes. The negatives is that it does take resources to do these, but I think the positives far outweigh the negatives when you're running mock codes. But bottom line, take-home points is that this can be done at any facility, big or small. You just need to do whatever works for your facility or your unit. The ED model is going to be a little bit different than an in-hospital model, but I think the bottom line is that we do need to practice low-volume, high-risk procedures and focus on what matters. Focus on CPR quality, defib time, ventilations, making sure you're not overventilating, team dynamics, communication, and then debriefing is absolutely one of the most important things. And so with that, I'm going to wrap up and hand back over to Janice. But here's my information. Again, please, stay in touch. I'm on social media, on Facebook under Nicole Kupchik Consulting and Education, and then on Instagram at Nicole Kupchik. And then I've got a podcast that I host for Stryker Physio Control. It's called Resus 10. So it's all about resuscitation in 10 minutes or less. And then I've got my own YouTube video show, which is kind of a fun show. So with that, Janice, are you ready to take it back and man any questions that we've got?
Absolutely. Thank you, Nicole, for that wonderful presentation. Just as a reminder to the audience, this activity has been approved for one contact hour of continuing education for nurses and respiratory therapists. Go to saxtesting.com/SL. You will need to register on the CE test site, complete the evaluation form, and upon a successful submission, you will be able to print your certificate of completion. The accreditation statement is listed below, and the on-demand version will be accredited for nurses and respiratory therapists. Now, with that said, we are ready for some questions. Nicole, you ready?
I'm ready.
Okay, the first question I have is coming from Vicky. She says, I work in an ER and would very much like to implement mock codes in our hospital. Who would be the best person or department to speak with first to get the ball rolling? And how did you get this program started in your hospital?
Yeah, so I think, the ED model is a bit different. I think it's almost easier because literally the ED, I would just run them locally. And so I think your nurse manager, director, of the ED, and then also your physician director, and then respiratory therapy. Don't forget about RT, because respiratory therapy is involved in your codes. But just start the conversation there, and then I would also get permission to use your real equipment, use your crash carts, but just start locally with your leadership and talk about why, and then kind of go with a plan of how you would roll these out. And I would definitely use this slide deck to kind of think about things. And then you're going to need simulation equipment. So whoever, maybe your clinical education department or your community training center, but you'll need to borrow simulation equipment to run these.
Okay, great. Our next question is from Ruth, and she asks, how do you get buy-in if you can't get it from management? Any suggestions?
Well, I don't know how you I don't know why management would not want to do this. I honestly can't imagine. This is okay, so have your statistics. I would say start there. Have your stats. Like, know what your outcomes are. And I can tell you, no hospital has glowing outcomes from in-hospital cardiac arrest. No one does. In fact, we all need to improve. When you look at the Get With the Guidelines outcomes, there is massive opportunity for improvement. And so start with your outcomes. And then again, I would want to know why. What is the hesitation to running mock codes? This is a very high risk, super low volume. And then I would say if you're still having problem, go to risk management and patient safety. Go to those two departments and find out, what you can do to get buy-in from them. There is not one nurse manager that should be making this decision. This is a hospital-based type program. So I would honestly go to your chief nursing officer, and I would want a really, really, really good reason as to why this cannot be done. To me, it's inexcusable to be denied to do this. To me, it's unfathomable, actually.
Okay.
Here's me all getting all heated right now, right? I
I
mean,
hear.
this is crazy, though. I mean, this is your sickest patient in the hospital. Why wouldn't you want to drill this and make sure your staff are comfortable?
Absolutely. I agree. Our next question is from Machkin. It says, do you have any thoughts for or against using the automated CPR device compared to regular standard compressions, I guess, during the mock codes?
Yeah, no, I mean, if you're working in a facility that has manual chest compression devices, use them in your mock codes for sure. The one thing, if you've ever heard me give a webinar on mechanical CPR, I always say, one of the key things of successfully using mechanical CPR is application. And absolutely during mock codes, you should be practicing application of those devices. So if you have them, use them during your mock codes for sure.
Nicole, our next question is from Matthew. Any suggestions on how to implement a mandatory participation for mock codes?
Well, yeah, I mean, I think you've just got to go to all your key opinion leaders, right? I mean, go to the chief nursing officer, the chief medical officer, the head of anesthesia, head of RT, and just go to those groups and just ask them, if I have people who don't want to participate, what should I do? How should I follow up? This program works well if everyone participates. And I think, I asked our chief nursing officer and chief medical officer to actually send communications down to the teams to remind them that this is an expectation. And I wanted them to say, here is the expectation of staff. And I'll tell you, by doing that up front, I really waylaid a lot of problems. But, I think what you're going to end up finding is that people actually want to participate. You'll have providers or nurses every now and then that get a little testy about it, but just don't do things like call a mock code when there's an emergency going on. Just make sure you don't ever do things like that, and just make sure that the hospital is okay and before you run them, but get buy-in from your leadership. If you do, it will make all the difference in the world into making these successful.
All right. Next question is from Daniel. What do you think about real-time feedback devices for measuring the performance during the mock code?
Yeah, no, absolutely. If you've got them, use them. Use whatever you would use in a real code. Use a metronome. Use feedback devices. Anything you've got, use them. Treat them as, treat these mock codes as real as possible. And, anything you've got that you would use in a real code, use it in the mock code.
All right. Next question is from Ken. What specific problems did the operators have with calling a code, and then what improvements did they have to make, or did you make?
Yeah, so like they weren't using the right line. So there's a line that basically like the calls should be going to, and they weren't like picking up that emergency line right away. Because a code blue call should supersede any other call coming into the hospital. And there was some issue with that. And then they weren't repeating. They actually sometimes were repeating the wrong information. And so we had to teach them to repeat whatever the caller said and then call that overhead. Like no joke, a couple times they called the wrong room number.
Okay, yeah, that would be important. Next question I have is from Dawn. Does the recorder chart in the EMR in real time, or do they chart in paper and then
Yeah.
transcribe it?
Yeah, so we did paper. If you're a facility that does EHR documentation of codes, I would say like get a practice environment. I would work with your computer group, your IT documentation groups, and see if there's a practice environment that they can document. I would do whatever you do in reality. I would do that in the mock codes. I would try to simulate reality as much as possible.
Okay, the next question is from Anne. Did you record your mock code drills?
A couple of them we did with permission of staff, and I'll tell you that's what some facilities are going to now is that they actually do full video recording of all their mock codes. I would say you don't have to, but it is helpful. We just didn't have enough time in these type of environments to play the videos back. But we did record a couple of them just to show to administration, and so so that administration could kind of see the challenges we're faced with. And but in some mock code programs, I know they'll record the entire mock code and then play it back as part of the debriefing. We just didn't have time to do that.
Okay. Kathy wants to know I'm sorry, yes, is there a specific place for when it's geared towards pediatric mock codes? Is there any information that they can get, or a website or anything they can go to for that?
Well, I mean, it's the same. You do everything the same. You would just, the only thing I would say do different is to just, like we would call, like in real life, if we have a pediatric code, we would say pediatric code blue room blank overhead. That would be the overhead call. So do that overhead call the same, and then run everything the same. So what I did was I worked with the head of the pediatrics, the medical director of pediatrics to run the pediatric mock codes. But do them the same, do them exactly the same.
Okay. Christina wants to know who coordinates and does the administrative work with regards to the mock codes.
Yeah, I mean, that's going to be different at every facility. I'm the one who did it at my facility. And literally what I would do is every month I would just make 4 times a month with my medical director. And sometimes he couldn't make it. Now, I mean, I just worked around his schedule, but we would create 4 times a month that we were going to run these mock codes. And then we'd show up a half hour before, get everything set up, and then just call it. And I never, like, I just had an open permission from administration to run them whenever I wanted to. So yeah, so I would just literally, it was me and the physician I worked with. And then again, I would call all those key people beforehand, make sure there were no emergencies happening in the hospital, and then we'd call it overhead.
Okay.
Yeah.
Awesome. Okay. Jacqueline has a question. Our facility often cancels our drills due to providers being unavailable. Do you think it's okay to run the drill even without the provider?
That to me would just be unacceptable. I don't know why, like, they can't break away for 20 minutes. And again, I'm just, not to be sarcastic, but the purpose of doing this is to train your team, and they are an essential part of the team. And they're usually, if you talk to a lot of nurses, if there's problems, it's usually with your providers. And so I don't know. I'm going to be super blatantly honest. If they can't break away for 20 minutes, then maybe it's not the time for the team. We never gave them an option of do you have time or not. I just made sure they weren't in the middle of putting in a central line or some big procedure, and then they didn't even know it. So they didn't have an option to opt out, because everyone can opt out, right? I mean, you can always find a million gazillion different excuses of why this isn't a priority right now. I don't know. I think it's essential to have them there, but I would say I wouldn't cancel the whole thing if they couldn't. I mean, so
Okay.
I just said, go both ways basically, but I think it's essential to have them there. And I just didn't give them the option of opting out. It called overhead as a real code. They didn't know till they got there that it was a mock code.
Okay. And I want to make sure I'm pronouncing this right. I hope I am. Nigra asked the question, do you think including mock codes in a pediatric skills fair is a good idea to ensure
Oh,
participation?
absolutely. Yeah, no, absolutely. If you've got, any opportunity that you've got in your hospital to get people comfortable with doing compressions, absolutely. But again, if you want to assess your team, that's not the place to assess your team. That's the place to do individual skills, practice your skills. To assess your team would be more of a systematic mock code.
Okay. All right. And just so you know, a lot of people did have a question or were inquiring about the form that you mentioned, the tool for the
Yeah.
mock code. So I know you had your email address up there. Just wanted everyone to make sure that they send you that. They can send you an email for that.
Okay. Yeah, and you know what else I could do is I'll send it to Sex Communications, and then they can post a PDF of it. I won't be able to send it to them though till tomorrow. So, but I'll do that. I'll send it to Sex so that they can post with the handouts.
Okay, sounds good. All right, and so at this time we are out of time for all of the questions. I want to thank you, Nicole, for your participation, and thank everyone in the audience for sending their questions. And I think we're going to turn it back over to Emily now.
I'd like to thank you both, Nicole, for this very informative presentation, and as well to you, Janice, for being our moderator today. It's been such a pleasure working with you both. And so with that, I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.